So let me just kind of start by introducing myself. So I'm Dr. Miller. I trained as a general surgeon in the military. I was in the Army for about 12 years as a general surgeon. But I mostly do minimally invasive robotic surgery and, of course, weight loss surgery. So it's myself and Dr. Shutnick. We're the two weight loss surgeons for all of Lakeland. And basically, we're kind of interchangeable to some degree. You'll see one of us throughout the process. But we work very closely on all our weight loss patients. So what we're going to talk about tonight is obesity in general, not just surgery. We're going to talk about, why are we having such an issue with obesity in our society? We're going to talk about what things lead to obesity, what are the factors involved in obesity. We'll talk about surgery as a treatment option for obesity, but we'll spend a lot of time talking about how healthy eating and healthy lifestyle play a part along with surgery. So a lot of people think that it's diet and exercise in one corner and surgery in the other corner, and they both kind of duke it out. Even a lot of primary care doctors think that. But I hope that by the end of the discussion tonight, you understand that what we're trying to achieve is healthy eating and exercise habits, and surgery is a tool that we add to those healthy eating habits to make them more effective and then to make them permanent lifestyle changes so that not only do you lose the weight, but you keep the weight off long term. So our goal isn't that you just lose a bunch of weight and then regain it. We want to see that the weight stays off 5 years later and 10 years later, and the surgery is a big part of that in terms of a tool to help you achieve that goal. So whenever we're talking about a problem, we needed to start by defining the problem. And for obesity, we kind of use a crude tool, and that's your body mass index. And basically that's your height and your weight, and that we come up with a number, and that's your BMI. And so when we're talking about BMI, what we're really talking about, and here's a chart that you can see, you look at your height on one end and look at your weight. But when we're looking at, who's kind of a candidate for surgery, what kind of BMI are we talking about? It's basically people with a BMI of 35 or greater, okay? So people with a BMI of 35 with some weight-related medical problem, like diabetes or high blood pressure, that would be a candidate for surgery, and people with a BMI of greater than 40. Now, if you're wondering what your BMI is, there's a card in the packet that you get, but you can also just get on your smartphone and Google BMI. There's all kinds of calculators. All you need to know is your height and your weight, and then you can get your BMI. Now, BMI is not necessarily the best tool to determine how significant your obesity is because, again, it's just your height and your weight. There's plenty of bodybuilders who are short like myself who actually have a high BMI, but they're actually fairly healthy. So it doesn't give us the whole story, but it's a simple and reproducible way of measuring it, so that's a starting point, okay? But what it doesn't tell us is, do you have diabetes? Do you have high blood pressure? Do you have sleep apnea? So there's a lot more that goes into obesity, and there's a lot more that we need to understand about you as a person than BMI, but that's at least a starting point, and it gives us at least a baseline criteria of what kind of group of people are we talking about who might benefit from the surgery. So this is probably the most important slide of the whole talk, and I think this really hammers down the point of why we care about obesity and why we're trying to treat it so aggressively. So in this chart, you can't read each individual thing, but these are each different body systems that are affected by being overweight. And if you look at that, basically high blood pressure, diabetes, pulmonary conditions, sleep apnea, knee pain, back pain, all these things are related to obesity. Even some forms of infertility are related to obesity. And so it doesn't just affect one thing. It's not a cosmetic surgery. This is a surgery that we do to improve your overall health. So if you take a group of patients who get surgery for weight loss and you compare it to a group of patients who are of the same BMI who don't get the surgery, this is a study that was done in Sweden a number of years ago, the group that got the surgery lived on average 12 years longer. And the reason for that is because of this slide here. It's how obesity is negatively affecting so many different body systems. Okay? So we talk about heart disease, heart attacks, all those kinds of things. Those are all obesity related. Hi, welcome, come on in. So when we talk about our goals for the surgery, it's not so much that we want you to lose weight, which we do and you will, but really what we want is for you to be healthier. We want to get you off your diabetes medications. We want to get you off your high blood pressure medication. We want you off your sleep apnea machine. And that translates into you living a healthier life and you living longer. Okay? So the goal of weight loss surgery isn't just to lose weight. The goal of weight loss surgery is to be healthy. All right. So what contributes to obesity? So there's going to be some genetic component to it, but it's not clearly just genetics. There's physiologic components to it. We're all kind of different. We have different metabolisms. There's all kinds of variables there. Individual behaviors, that's probably the biggest one. How we eat, when we eat, all those kinds of things. Those are things we're going to talk about a lot during this talk. Gender, well, men and women are different. We hold our weight differently as well. You know, for the ladies here, unfortunately, it's a little bit tougher for you to lose weight, and you tend to gain weight more around your hips more often than the abdomen in general. Men, you tend to gain weight more centrally, and men, actually, that central weight tends to be a little bit more dangerous, meaning it tends to be more associated with heart attacks, high blood pressure, and other medical problems like diabetes because it's more what we call metabolically active fat. So there's differences between the genders. Psychosocial is a big aspect of it. When I talk to patients who have lost a lot of weight, sometimes dealing in social circumstances can be difficult because when do we get together? Well, we get together over meals. We get together on the holidays, and what do? We have a nice meal. And so there's all kinds of different psychosocial aspects to this. And then there's also psychological aspects. Sometimes we eat because we're bored. Sometimes we eat because we're depressed. Sometimes we're depressed because we eat. And so depression is another thing that's kind of, you know, when you think of all the things that obesity affects, you might not think of depression, but those two are tightly linked as well. All right, so there's lots of different variables that impact why we're obese. This is a chart kind of looking at the United States and the percent of the population with a BMI greater than 30. So that's BMI greater than 30 is considered obese. As we've progressed over the decades, the problem has just gotten worse. And in fact, right now in the state of Michigan, about a third of the population meets criteria for surgery. So a third of the population is obese. So this is a problem that's widespread and I think needs to be addressed. So why are we overweight? Well, okay, well, we eat too much. This is probably obvious to most people, like, okay, well, you eat too much. Well, what do we really mean by that? Well, probably the biggest thing I would say is rather than, if I were to say, when do you stop eating? Most people would say, well, when I'm full. And I would suggest to you that if you stop eating when you're full, you've probably already eaten too much. All right? So what we recommend is that you don't stop when you're full. What we recommend is you stop when you're no longer hungry, which is a different thing than when you're full. Okay? So we recommend things like chewing your food well. Well, why do we recommend chewing your food well? It doesn't have so much to do with chewing your food. It has much more to do with slowing yourself down so that you take time so that you can recognize, oh, I'm not really hungry anymore, and stop eating before you're full, because by the time you're full, you've probably already overeaten. Okay, so eating slowly, chewing your food, these are things that we're going to stress before the surgery, but after the surgery become extremely important because you'll have a smaller stomach and you'll get full quickly. And so that kind of reinforces that idea of eating smaller portions, eating more slowly, so that you stop when you're no longer hungry as opposed to when you're full. Okay, so that's what we mean by eating too much. All right, so in our society, it's pretty easy to see why we're eating too much. These are kind of pictures of, you know, a Burger King Whopper in 1954 compared to 2004. Okay, looking at the French fries from McDonald's, even the a bottle of Coke. Our portion sizes have gone up, and as a result, we are eating more calories. Not only that, probably the food that's cheapest, easiest, most convenient, most readily accessible is going to be food that's bad for you. It's going to be high in calories and low in nutrients. Well, if you want to eat healthy, what is it going to take? That's going to take probably more time, more money, more effort. You're probably going to have to make it yourself. So these are tough changes to have to make, and our culture and society aren't exactly helping us with that problem, which is why you see the skyrocketing obesity rates. All right, so we also don't eat enough. All right, okay, I just started by saying we eat too much, and now I'm saying we don't eat enough. You're like, well, what is it? Well, the answer is it's kind of both. So when I talk about not eating enough, if I were to poll most people that I talk to who are obese, and I would ask them, well, how many meals a day do you eat? Probably the most common number would be 1 or 2 meals. All right, that's probably the most common thing. Everyone's kind of like, yeah, shaking their head, right? So that's interesting because, you know, normally say what's normal? Well, people normally eat 3 meals a day. Well, what we actually recommend is actually eating more frequently, about 6 feedings a day, which includes small healthy snacks. And the reason for that is because we want to engage your metabolism and give your body the nutrients that it needs so that it also will burn calories. And the best analogy of this that I've heard is it's kind of like you're burning a fire, and you can take a whole stack of wood and drop it on the fire and kind of just smother it, which is kind of what we do when we eat 1 big meal a day. Or you could put 1 log on the fire, let it burn, keep it hot, and then another log on the fire, let it burn, keep it hot. And that's kind of more like eating frequent meals throughout the day. Now, when we're eating frequent meals throughout the day, what's also important to remember is the timing of the meals is important. So eating breakfast as the first meal of the day is extremely important. But a lot of people who get up, they'll get up and they'll drink their coffee and they won't eat breakfast, and then maybe not even get lunch, but at dinner, they'll eat a bunch of calories. So what is that telling your body? Your body is basically in starvation mode throughout the day, hasn't seen any calories, hasn't really started its metabolism, and then you load it with a bunch of calories right before going to bed and storing all the calories. So by that eating pattern, you're teaching your body to store on and hold on to as many calories as it can. And actually, throughout human history, you know, starvation and famine have been the big problems, right? An overabundance of food hasn't been a big problem until recently, okay? So our bodies have been, you know, trained to hold on to calories, make the most of calories, and by not eating breakfast in the morning and not giving your body some calories to start your metabolism, you're basically kind of engaging your body into a practice of going into store as many calories, burn as few calories as possible, and then by eating late at night, you're telling your body to store as many calories as you can because you never know when your next meal is going to be. Whereas what we're recommending is frequent small meals and always eating breakfast. And if you're going to eat a large meal, the large meal should be at breakfast, all right? Because you're engaging your metabolism and you're burning those calories throughout the day. You're letting your body know it has enough calories that you can burn calories. You don't have to store everything. All right, we also recommend kind of choosing the right foods, eating higher fiber and higher proteins and less sugar and non-complex carbohydrates. All right, so we eat too much, we don't eat enough, we eat the wrong foods, okay? I think most of us probably would have guessed, yeah, the wrong foods. Yeah, what is good nutrition? Fruits, vegetables, protein, dairy, those are in general good foods. White foods tend to be the bad foods, so that's kind of an easy way to remember, you know, the simple carbohydrates that, you know, kind of just get stored and turn into sugar and then they turn into stored fat. Those are like white bread, white rice, pasta, potatoes. There's just a lot of calories, not a whole lot of nutrition in those. And so, you know, avoiding those is helpful as we're trying to lose weight. All right, and so we eat too much, we don't eat enough, we eat the wrong things, and then we're not active enough. Okay, this one's probably best seen when you go to the elementary schools. So if you go to an elementary school today versus going, you know, to an elementary school 50 years ago, kids don't look the same as they used to. And for kids growing up, some of it's the diet, but for kids especially, a lot of it's inactivity. Okay. For adults too, rather than do a job where you're working at a factory or manufacturing, you're more likely to have a desk job, unfortunately, at a computer all day. Having a more sedentary lifestyle tends to be more common. There's less time to exercise. We work more hours of the day, but we have, you know, less time to exercise. It becomes inconvenient. And so that's another factor in why we just have this problem with obesity. So every calorie you consume needs to be used. So obesity can become very complicated, but at one level it can also be very simple. It's still always going to be calories in and minus calories out, and you're either gaining weight or you're losing weight. Either gaining calories or you're losing calories. Okay, so on some level it's that simple. It gets much more complicated as we talk about, well, what calories are you getting in and how readily are you burning the calories, and that can become very complicated. But at some level, every calorie you eat needs to be burned, and that's where exercise helps you out. And doing a little bit of exercise can go a long ways in terms of revving up your metabolism and burning calories. Now, when you're looking at it, a diet and exercise, it's not a 50-50 diet and exercise, okay? Much more importantly a much more important emphasis should be placed on the diet as opposed to the exercise. Having said that, the exercise is important for your overall health, for your cardiovascular health, and does help you burn calories if done appropriately with a balanced diet. The caution with exercise is, well, so say you go to the gym and, you know, New Year's resolution, you say, I'm going to lose weight, but I'm going to go to the gym. So you get on the treadmill and you burn 200 calories on the treadmill and you pat yourself on the back, you did a great job. That's great work, you burned 200 calories on the treadmill. And then you go home, and then by the time you get home, you're really hungry because you just burned 200 calories at the gym. Well, if you can sit down and you eat 2,000 calories, well, you just got a net positive of 1,800 calories. All right, so that sometimes can be counterproductive. So what we want is a balanced diet, healthy lifestyle, and then we add the exercise to that, okay? If you neglect one or the other, it doesn't really work well, and the diet is a larger component of it. So what you don't want is for the exercise to derail your diet, okay? And this is, again, where the surgery kind of plays into it, because we kind of help guide you along that process so that you're working on the diet and then adding that exercise, and you have a good balance so that you can achieve the weight loss. Okay, so there are other things that can be tried other than just going straight to surgery, and certainly this is a process. There are basically behavior modifications that can be done. There's diets that can be tried. Most people who have come here have tried the diets and have tried exercise. There's varying degrees of success that you can get with diet and exercise on its own, but part of the problem is you're kind of facing an uphill battle by the time you get here already, okay? So there's a lot of habits that get formed that are hard to break, and so diet and exercise by itself, it works as long as it's tried. But then the second it's, you know, not tried, then you just regain the weight. So a lot of people have success on diet and exercise, and then they go off the diet. The holidays come every year. Life stressors happen. You know, something stresses you out at work, you go home, you get off your diet. You know, all 8 cylinders need to kind of be firing at the same time. One goes down and the whole house of cards kind of crumbles. Okay, so what we're trying to do is avoid that situation where you do well for a period of time and then you fall off the rails. What we want is to kind of give you a fresh start to a new lifestyle of healthy eating and exercise. Okay, so when we're looking at other options besides surgery, there's things like drugs, pharmacotherapy, medications that you can try. But again, the problem with those is as you start them, they're good for a while they last, and then you may have to come off of them for side effects, or as soon as you come off of them, you can regain the weight. So it's not really a long-term solution. So then why do we do the surgery? Well, it's not a cure. That's the first thing that we should say. It's not like we do surgery to fix you, okay? What we're trying to do with the surgery is help you to kind of wipe the slate clean and get a fresh start so that you can choose how you're going to eat and how you're going to be active for the rest of your life, okay? We want you to make healthy food decisions that become new behaviors that you have for long enough that they become habits, okay? So right now, with your weight loss, it's kind of like you're walking up a hill that's like this steep, okay? That's your diet and exercise. One thing goes wrong and you kind of slide down. All right, with the surgery, you still have to walk up the hill, but what we're trying to do is make the hill a little less steep, make it a little bit more manageable, okay? Most people who are trying diet and exercise by itself, it works for a period of time and then it stops working because they get off the diet and exercise. About 95% of all diets fail within the first year, okay? And I guess the point that I would emphasize with the surgery is the difference is the surgery helps you break those old cycles, okay? And that's where it's an effective tool, but like any tool, you have to use it appropriately, okay? And so what I'll explain as we go through the talk tonight is that it's a process of getting to the point where you're ready for surgery, and then after the surgery, it's a process of retraining your brain and retraining your body of how you're going to eat and how you're going to exercise. Okay? So it's not a cure-all, it's a tool in your toolbox. But it's kind of like, if you have a hammer, it makes it pretty easy to nail a nail in the wall. If you had to just push a nail in the wall, that'd be pretty difficult. But you still have to pick up the hammer and swing it, and that's kind of the surgery. It's a very effective tool, but it's still just a tool. And as you have the surgery, you're going to lose weight, but what you need to keep in mind is the surgery just didn't lose the weight for you. A lot of patients lose a bunch of weight in the first year or two, and they think, the surgery fixed everything, I'm cured. And that's not really what we're after. What we're after is, the surgery will help you change those behaviors, help you eat small, frequent meals, help you make healthy food choices because you won't be driven as much by hunger, you'll be driven by a desire to eat the right foods. But if you're not recreating new habits, if you're not retraining your brain and your body to eat differently for life, make these permanent changes, then you won't have permanent results, okay? So the surgery can be very effective, but it's very effective if you understand that that's what the surgery is doing for you, okay? It's not losing the weight for you. You're doing that yourself, but the surgery will help you kind of wipe the slate clean, break those old habits, and develop new healthy habits, and that's really what we want. All right, so there's some patients who just can't get surgery, and this is kind of a list of contraindications to surgery. What I would point out about the slide is most of these things that are listed here are kind of relative. So the first thing it says is unstable cardiovascular disease. What does that mean? That means if you're actively having a heart attack, maybe now's not the time for surgery, okay? Having said that though, if you just recently had a heart attack and you're obese, maybe it's time to start thinking about surgery, okay? Because that's one of the reasons we're doing surgery. Obesity is the #1 preventable cause of death in the United States, okay? It just passed smoking, all right? And a lot of the other conditions that are considered the #1 killers, like cardiovascular disease, well, if you have obesity, you're at higher risk for cardiovascular disease, okay? What we don't talk about, because it's not like a cancer diagnosis, right? If you get a cancer diagnosis, it's like, oh boy, you get in the room, you sit down, and you say, you got cancer, right? It's very solemn, and it's like, oh boy, I have cancer, what do I have to do? But with obesity, we don't really do that with patients. We don't say, this obesity is going to cause high blood pressure, diabetes. You could have a heart attack. You could have a stroke. You could have sleep apnea and have sudden respiratory failure. We don't really talk about those things because they're kind of in the future. We don't really think about them. They're more abstract. But the reality is your obesity is slowly killing you, and something needs to be done about it. And I think that when we're looking at this list, there's some conditions where there are direct contraindications to surgery, but a lot of these things are reasons for surgery if you can get healthy enough to get the surgery. The few things that I would point out is substance abuse and active smoking. Those are contraindications, and we won't do surgery if you're smoking. The good news is we will help you quit, okay? The reason we won't do surgery on people who are actively smoking is because the risks of the surgery are too high, okay? We are nationally accredited as a Center of Excellence for Bariatrics, and we're very proud of that. All our data gets tracked both at a state level and a national level. We do not like complications. We want the surgery to be as safe and effective as possible. And if you're a smoker, it makes the risk of the surgery too high. Now, there's some patients who might be like, okay, I understand I'm higher risk, but I still want to get my surgery even though I'm a smoker. And unfortunately, what I will say is, well, the risks are too high for me. I'm not willing to do the surgery, okay? Because I want safe surgery with no complications that's very effective. Now, nothing's perfect, but we're going to get as close to perfect as we can, okay? And if you're a smoker, the risks are just too high, okay? So we've had a lot of patients come through the program that were smokers. We've had a lot of patients that quit because they wanted to get the surgery, and it's changed their life. And you talk about something that's going to improve your health, stopping, smoking and then losing 150 pounds. Yeah, that's a pretty good start. That's a pretty big improvement, and that's a pretty big change to your overall lifestyle, okay? It's not really sacrificing or giving it up something, at the end of the day. It becomes gaining a new life, okay? So if you're a smoker, we'll help you quit, and now's a good time. All right, so I'll talk a little bit about the surgeries. There's basically two different categories of surgeries. Some surgeries have kind of come and gone, but the two surgeries that we do are kind of listed in bold: the sleeve gastrectomy and the Roux-en-Y gastric bypass. And I'll kind of discuss each of these individually. So, but for both of these surgeries, we do them right across the street here, and we do them laparoscopically with the assistance of a robot. And so that's what's seen in the picture here. And what we like about the robot is we think it's the safest way to do the operation. We think it improves our outcomes, and we think it improves the patient overall experience in terms of less pain, shorter hospital stays. The benefit of the robot is that we get better visualization. Things are magnified 10 times. Everything's in high definition. And actually, we have two cameras within the one cylinder of a camera that gives us depth perception, so we can see the structures well. We also have better mobility of our instruments, so we can move our instruments like our hands. We have full range of motion, even though we're going through small, tiny incisions. And so using this technology, we think gives us safer outcomes. And again, we're all about safety and lower risk and better results. So we do these with the Da Vinci robot. Okay, so the first operation is what's called a sleeve gastrectomy. And this is basically where we remove about 75% of the stomach. 60 to 85% is what's up there. And your stomach looks like a sleeve, which is why it's called a sleeve gastrectomy. So this is a nice operation because it's technically a little bit simple. It's easy to explain to people. Well, they just made my stomach look like a sleeve or like a little tube. And they took out most of my stomach. It's easy to kind of understand, like, well, if your stomach is small, you'll eat and get full quickly, and then you'll eat less, okay? And that helps train your brain and your body that, oh, I can eat small meals and just more frequently, and that's better. But in fact, it actually probably works better than expected, because this portion of the stomach that we're removing is kind of the expandable portion of the stomach that kind of can expand to accommodate large meals, but it also secretes a hormone called ghrelin, which stimulates appetite. So by removing that portion of the stomach, we probably also decrease overall appetite. So I had a patient this week who said, yeah, I'm just not that hungry like I used to be. And I said, well, that's good. And the reason it's good is because then you can choose the way you eat, right? So it's good because, and not just because you're not as hungry. What's good about it is when you're making healthy choices what you eat, instead of having your hunger drive what you're eating, then you can make better choices. And you make those choices consistently, they become habits. And once they become habits, eating healthy becomes less of a big deal. It's just your habit, okay? And that's where you get long-term sustained weight loss. So it's a nice option, the sleeve. It has lots of advantages in terms of we're not rearranging intestines, so there's no malabsorptive component to it. We're, not disconnecting or reconnecting anything. We're just removing a part of your stomach. And you get good results in long-term weight loss with that. You do still need to be on a multivitamin for the rest of your life after this surgery, but there tends to be less problems with malabsorption. The disadvantages, and I don't really know if this is a disadvantage, but we list it as a disadvantage, is that it's not reversible. Once we take out your stomach, we can't put it back in. Your stomach might get a little larger over time, but there's, once the stomach is out, there's no putting it back in, so it's considered, not reversible. But with the goal being that we want a permanent solution, I'm not sure if that's an advantage or disadvantage, but we're listing it as a disadvantage here, I guess. But you can theoretically stretch the stomach over time. You could kind of overeat your stomach, and that could lead to weight gain. Again, if you're not making those conscious decisions to change how you eat. All right, it does have some risks of leaks or scar tissue formation or just not losing enough weight. There's also risk of reflux afterwards. When we get closer to your initial evaluation, when it's a one-on-one visit, we'll talk about each of these operations in much more detail and much more depth. But those are some of the general complications that can happen. All right, the other operation that we do is what's called a Roux-en-Y gastric bypass. This is kind of the gold standard in terms of weight loss surgery. This operation's been around for decades, and we have lots of good long-term data on it. If an operation's been around for 50 years and it's still around, it's probably a good operation. But basically, what we do with the gastric bypass is we create a small pouch that's in your stomach that you see up there, and we bring up a limb of intestine that we connect to that pouch. So the majority of your stomach is then bypassed. So what that means is the food goes down into your pouch, and you get full quickly because you have a tiny little pouch. And then the food travels down your intestine there without mixing with digestive enzymes from your liver or your pancreas until further downstream where it marries up with this intestine down here. Okay, so that's the Y on the Roux-en-Y gastric bypass. This is a little bit more difficult operation to explain to people. A lot of times I'll tell people this and they'll have a confused look on their face like, you're going to do what? So we create a small pouch and then like bring up my intestine. So it's a little bit more detailed to explain. But it's been around probably the longest and has very durable results. So in terms of what your results that you can expect, you can expect to lose about 75 to 80% of your excess weight. And so what does that mean? Okay, so your excess weight is what you weigh at your heaviest minus your ideal body weight. Okay, so your ideal body weight, to give you an idea, it's what you might have weighed as a senior in high school if you were a thin kid. Okay, it's not a weight we're going to get you down to. But say if your current weight's 250 pounds and your ideal body weight's 150 pounds, your excess weight would be 100 pounds, and we could get you to lose about 80 pounds, okay, for instance. So losing about 80% of your excess weight is a pretty substantial number, but we're not going to get you rail thin. That's not the goal, okay? Both of these operations are, in general, an overnight stay in the hospital, home the next day. So the advantages with the gastric bypass is that you have pretty rapid weight loss, pretty well-sustained weight loss. In my mind, the real advantage of the gastric bypass is for patients that have insulin-dependent diabetes. So if you're a diabetic who's on lots of insulin, this is a good operation for you because it has beneficial effects for curing diabetes. If you already have very significant gastroesophageal reflux, so if you have bad heartburn that's pretty consistent and you're always on medication for that, the gastric bypass is another operation that helps with that as well as the weight loss. So that's another possibility. It's considered reversible, so we consider it an advantage here because we're not taking anything out. So we've just kind of created a pouch and reconnected things. We've kind of redone the plumbing, so to speak. And so we can always undo that, but I would say that this shouldn't be thought of as reversible in general because that would require another surgery that has its own set of potential complications from previous scar tissue and the like. So I don't think it's really good to think of any of these as reversible, but technically speaking, if we had to reverse you from a gastric bypass, we could. All right, so there's lots of potential complications with bariatric surgery. All the complications tend to be, pretty, I wouldn't say rare, but they're pretty small numbers. But there's some real complications, having a staple line leak or having an ulcer that can develop at your pouch, or a narrowing of stenosis, having blood clots go to your lungs, what we call pulmonary embolus, that's a complication, having bowel obstructions or vitamin deficiencies, or bad reflux after your surgery, those can be potential complications. When talking about the complications, and I spend a lot of time with patients. When you meet with me one-on-one, we'll spend about 15 minutes, and I'll talk about all the potential complications. And it might scare some of you out of surgery, but hopefully not too many, because the reality is this slide. So patients with a BMI greater than 30 have a 50 to 100% increased risk of premature death. And when you compare patients who've had bariatric surgery versus patients who don't get the surgery, you're much more likely to live longer if you get the surgery. So the reason I have an airplane in this slide is to kind of make the point, when people drive to the airport, they're always worried about the plane crashing. And they didn't stop to think that the drive to the airport was more dangerous than the plane crashing. And it's kind of the same thing with bariatric surgery. You're always worried about the complications of surgery, right? Because all these risks are coming around a very defined period of time, and right around the surgery. And we don't think about the heart attack that you're going to have in a few years, right? So overall, you're safer getting the surgery than not getting the surgery. It doesn't mean it's, there's not complications, but we kind of have a hard time assessing risk sometimes. And so, I'll never talk someone into doing the surgery, but the facts simply state that getting the surgery is safer than not getting it for patients that are morbidly obese. Okay, so kind of where do we go from here? So, like I said, it's a process getting to the point of surgery. Surgery is a tool that we use to help us lose weight. But how do we best utilize that tool? Well, a lot of it has to do with what you do before the surgery, the work that you put in before the surgery. So part of this is for insurance requirements, but a big part of it's just so that we know that you're ready for surgery. But because what we want is for you to optimize your chance of being successful in the long term, not just a year after surgery, but 5 years and 10 years after surgery. So basically the process starts with a consultation with myself or with Dr. Schutnick, and we'll sit down, we'll talk about your whole medical history, your weight loss history. We'll kind of discuss which surgical options would be right for you. We can discuss the pros and the cons, and then we get more in detail than what to expect from the surgery. And after that, we have you go to 5 shared medical appointments, or SMAs is what we call them. And these are great because what we do is you come in for your appointment, and you'll meet with one of our nurse practitioners, where it's just you and the nurse practitioner, so you have some individual time where you're just talking about yourself without anyone else around. And you meet with a dietitian and do the same thing. But then you meet as a group. So you go through as a group, and then each month we discuss specific topics for that month as you go through the process. And so what we like about the group setting is, someone else might ask a question that you didn't think about. Or you might ask a question that somebody else didn't think about. Or when you hear, them discuss a topic, that might bring up some other questions that you might want to ask someone else in your group. Or if you're looking for what vitamin supplements to get, you can use other people in your group as a resource. So as we're giving out the information, it's a lot of the same information, but going through as a group kind of increases your resources, while at the same time giving you some individual time to kind of balance out the individual and the group time. So you have your initial one-on-one appointment with the surgeon, 5 group classes that you go through, and then you'll meet with the surgeon for your last visit to make sure you're ready for surgery, that you still think that's an appropriate step for you, and then to get you submitted and scheduled for surgery. Okay, so this is basically, again, just talking about the SMAs, the shared medical appointments. They're 90-minute sessions. We try to keep them fairly on the small side. 12 would be the max. Most of them are probably around like 6 different people in the group. It's a non-threatening, it's a safe environment. And it usually tends to be a better way of going through. It's a lot of steps to get to the surgery. There's lots of requirements, and for good reason, because we want you to be ready for surgery. But if you're going through with other people, it makes it a little bit, I think it makes it a little bit better than trying to go through yourself and having all these appointments. I also would recommend going to our support groups. We try to get patients who've had the surgery come to the support groups to talk to people who are considering the surgery, because I've never had this surgery, and I don't think of all the things that a patient goes through. Now, I'm taking care of lots of patients, obviously, who've done this. I've done the surgery on a lot of patients, but I don't necessarily have the same experience. So when I was in the military, I started a bariatric program when I was stationed in Landstuhl, Germany, and one of the first things I did was create a support group. Now, I wouldn't be directly involved in the support group because it needs to be kind of a separate environment where patients can go and kind of say what was good about the surgery, what was bad about the surgery, and having the surgeon there was probably not good for, allowing patients to do that. But what I found was patients would always, think of things that I wouldn't necessarily think about. Oh, you get your surgery, you lose a bunch of weight. Well, I'd have patients who would go to work and have to wear professional attire at work. Well, as they were, I had these female employees that were going, down 12 sizes in 12 months. That's a lot of clothes to buy. I didn't even think about that. Right? So what they did is, amongst themselves, they organized a group where they had a clothing exchange, and they would just come and donate clothes and arrange clothes by sizes so they can trade clothes, so that at the end of the 12 months or 18 months or how long, once their weight stabilized, they could just buy one new wardrobe as opposed to buying 12 different sets all the way through. So there's all kinds of things that patients who go through the process will think about. There's all kinds of resources on Facebook and other social media groups where you can talk to people who've had this surgery. You can hear bad experiences and good experiences, but it's nice to utilize people who've gone through the process, and I encourage you to go to our support group so you can kind of hear from people who've been through the process, what it's like, because there'll be lots of things that people who've gone through the process think about that I won't necessarily relate to, or I won't even consider. It's a little less so now because I've seen so many people go through it, and I hear about the recurring themes and issues. But talking directly to a person who's been through the process can be very, very helpful for you. Okay, so it's a big commitment. Your responsibilities are to basically to attend every session. We can't, if you have to miss, you gotta let us know, and we can try to arrange to have you seen individually. But really, it's important that you be committed to the process. And again, being committed to the process and having success during the process is what's going to ultimately lead to long-term success after the surgery. Okay, the surgery is just one component to this entire process. It's a very important component, but without the groundwork, set up beforehand, you can't expect to have surgery without, doing all that preparatory work to get you ready in the right frame of mind, so that you can, once you have your surgery, can maximize on that opportunity to succeed in your long-term weight loss. All right, so this is kind of a diagram. You can't necessarily read it from the back, but basically what this is showing is, it's a 6-month process even before the surgery happens, but then even afterwards, it's a process, okay? So we like to see you at a week after surgery, at a month after surgery, and then at 3 months, 6 months, and then a year. And we want to do this to make sure you're on the right track, that you're getting the nutrients that you need, that you're making the good, healthy changes that you need. Because again, we're not really interested in just operating on you and saying, okay, let's see how that works for you, see you later, bye. What we want is for you to lose the weight in a healthy way, and we want you to get off your high blood pressure medications, off your diabetic medications, off your CPAP machine, and we want your weight loss to be sustained, not just for a year, not just for 2 years, but for 5 years, for 10 years, and moving forward, because we want those changes to be permanent, and that's our long-term goal. So the surgery, the whole point of this slide is the surgery is just one point in the middle of this whole process, and the weight loss can start now. Okay, that's really what we want to see. All right, so here are just some of our success stories. These are actual patients that have had surgery here at Lakeland. We can show a bunch of these. These are just some that we picked out. And what I like about these is, with the before and after, the smile is always bigger than the after. And the reason I like that, it's what you realize in talking to patients is this isn't just a cosmetic surgery. This isn't just a oh, I want to be healthier surgery. This is kind of a new opportunity at life type of surgery. And the patients that have gone through the process, they really have taken hold of new opportunities in their life to have more energy. They're going for hikes with their grandkids. They're able to keep up. They get promotions at work that they probably didn't get before, just because there's a bias against them, or they don't have the energy to succeed, or they don't have the confidence to succeed. Okay, and so it really is a transformative surgery, and I really do think that this is a one operation that does more to improve a patient's health than any other operation there is. Okay. So with that, the next step in the process is for you to kind of fill out the form that's in your packets. What we do with that is we take down your information, and if you're interested in more, you can turn it into either myself or Beth, who's here. We'll go through and look at your information in terms of your insurance. We'll give you a call to schedule your initial consultation with me. And with that, if there's any questions, I'm happy to answer them.